Welcome to the Australian Dental Council Explainer podcast. I am so glad you're joining us today, especially if you are an overseas trained dentist, an OTD prepping for the exams, or maybe a current ADC candidate.
Yeah, or even a dental student or oral health therapist here in Australia looking to really sharpen that clinical reasoning.
Exactly. Because today we have a massive deep dive lined up. We are pulling from an incredible stack of sources today, primarily excerpts from Odell's Clinical Problem Solving in Dentistry.
Right, covering the third, fourth, and even peeking into the upcoming fifth edition, which is super exciting.
Super exciting. Plus, we're bringing in Master Dentistry Volume 1 and a bunch of actual ADC communication task old scenarios. So the mission today is a very technical, evidence-based exploration of oral medicine and pathology.
Which is, let's be honest, the stuff that keeps a lot of candidates awake at night.
Yeah.
We're talking diagnoses, reading radiographs, soft tissue management, and patient communication.
Oh, absolutely. But before we get into the weeds, I have to state our mandatory disclaimer. This deep dive is purely educational. We are not commercially endorsing any of these textbooks or products we mention.
Yeah, we're just here to help you synthesize all these complex guidelines into something you can actually use in the clinic.
Okay, let's unpack this. If you look at modern dental exams like the ADC or the ORE, they have totally shifted away from just rote memorization.
Oh, completely. The pedagogy has completely pivoted to case-based clinical reasoning. Because, when a patient is sitting right in front of you in pain, reciting a list of symptoms from a textbook isn't going to save you.
Right. You have to actively reorganize all that academic knowledge under intense pressure. And the Odell series really hammers this idea of cognitive biases.
Yes, specifically premature closure and availability bias. Premature closure is when you see one familiar symptom and just lock in your diagnosis immediately, ignoring everything else.
Which is so easy to do when you're rushed. And then availability bias, I always think of this like a mechanic. Imagine a mechanic who just fixed 3 cars in a row with faulty alternators.
They're completely primed for it.
Exactly. So the 4th car rolls in, won't start, and the mechanic just assumes it's the alternator again. They completely miss that it's just a simple dead battery. How do we practically avoid that in dentistry, especially with a vague complaint like pain on biting?
Well, pain on biting is the perfect example because it spans multiple disciplines. Is it an endodontic issue, like a dying nerve? Or a periodontic issue, like a lateral abscess?
Or just a high filling from last week, right? Like occlusal trauma.
Exactly. The only way you avoid that mechanic's trap is by enforcing a really strict, systematic approach to your history-taking and clinical exam every single time. You can't let the last 3 root canals you did dictate your next diagnosis.
That makes total sense. Now let's transition to something that really triggers that availability bias radiographs, specifically interpreting complex hard tissue findings.
Oh yeah, radiographic interpretation is a massive hurdle in the clinical exams.
So case 2 in Odell presents a multilocular radiolucency, the classic soap bubble appearance in the jaw.
The honeycomb or soap bubble.
Right. Why does it actually look like a cluster of bubbles on the x-ray in the first place?
It comes down to how the lesion destroys bone. As an aggressive lesion grows inside the canthallous bone, it doesn't destroy everything evenly. It leaves behind these thin, residual walls of cortical bone.
Oh, I see. So on a 2D radiograph, those overlapping bony walls just look like individual compartments.
Exactly. So when you see that, you immediately have to think of 3 main culprits for your differential: odontogenic keratocysts, ameloblastomas, and central giant cell granulomas.
But you can't just tell which one it is from a standard 2D panoramic x-ray, can you?
No, absolutely not. A 2D image is basically deceptive. That is why the guidelines mandate using a cone beam computed tomography, or CBCT, for these lesions.
Right, because you need to see the lesion's relationship to vital structures in 3D. Like, is it encroaching on the inferior alveolar nerve or pushing into the maxillary sinus?
Exactly. Or is it causing root resorption, which heavily points toward an ameloblastoma rather than a keratocyst? You need that volumetric data.
Let me ask a really specific technical question from the sources about that. Say the biopsy comes back as an ameloblastoma. Does the actual histological type of ameloblastoma really matter for the treatment plan?
It absolutely matters. It fundamentally changes the surgical reality. If it's a unicystic ameloblastoma, the surgeon can often be more conservative, maybe enucleating it and using a chemical agent like carnoise solution.
Which basically chemically burns any microscopic remnants, right?
Right. It's a potent fixative that chemically destroys the satellite cells so they don't recur without taking out healthy jawbone.
Mm.
But if it is a solid or multicystic ameloblastoma, carnoise won't cut it.
Because it infiltrates further into the bone.
Precisely. You have to do a radical surgical resection with wide margins. So that pathology distinction literally means the difference between a small procedure and someone needing a fibula-free flap to rebuild their jaw.
Wow. Speaking of losing jawbone, the sources pivot hard into osteonecrosis here too.
Yes, specifically medication-related osteonecrosis of the jaw, or MRONJ. It is a highly tested topic.
Because if a patient is taking bisphosphonates for, say, osteoporosis, and you just go ahead and pull a tooth without checking their medical history, you're setting off a bomb.
A completely iatrogenic preventable bomb, yes. Those anti-resorptive drugs paralyze the osteoclasts, the cells that tear down old bone.
So the bone literally can't remodel to heal the extraction socket.
Exactly. The exposed bone just dies, loses its blood supply, and becomes necrotic. So the key takeaway is always thoroughly review the medical history before picking up the forceps.
Okay, let's move from the bone to the mucosa. Soft tissue pathology. Because I feel like soft tissue lesions cause the most anxiety for both the practitioner and the patient.
Oh, without a doubt. They're notorious for mimicking each other, so they demand incredibly strict clinical protocols.
Odell's case 45 is a great example. It's a 52-year-old woman presenting with a white patch on her tongue that won't rub off.
Right, the clinical term for that being leukoplakia. But remember, leukoplakia isn't a true diagnosis, it is just a clinical description.
Exactly. So what are we really trying to rule out here in the differential?
The absolute priority is to assess for cellular dysplasia and frank squamous cell carcinoma. You cannot miss oral cancer. But you also have to consider systemic conditions like lichen planus.
Which is autoimmune, right? And the sources also mention assessing their social history, like if the patient uses betel quid.
Yes, betel nut chewing is a major risk factor for oral submucous fibrosis. The tissues become heavily cross-linked and incredibly rigid, leading to severe trismus.
And it carries a really high rate of turning malignant, right?
Very high, which is why a biopsy is totally non-negotiable for these white patches. And the texts outline some strict technical rules for handling that tiny piece of tissue once you excise it.
Yeah, the golden rule is that you must place the tissue into a container with 10 times the tissue's volume of 10% formal saline. Why that exact ratio?
That volumetric ratio guarantees the chemical fixative can rapidly and completely penetrate the entire depth of the tissue before the cells start to degrade.
Okay, wait, I have to play devil's advocate here. What if a busy clinic runs out of formal saline on a Friday afternoon and they just drop the tissue into surgical spirits? Like, is that like preserving a delicate artifact in battery acid?
What's fascinating here is that using the wrong solution literally destroys the diagnostic evidence. Without the precise formaldehyde cross-linking, the tissue undergoes autolysis.
Autolysis, so the cells basically digest themselves.
Exactly. They rot in the container. When the pathologist eventually slices that tissue and puts it under the microscope, the cellular architecture is totally obliterated.
Oh, wow. So they can't even tell you if it's cancer or just a benign callus.
They cannot. So you put the patient through surgery for nothing, you ruin the evidence, and you critically delayed a life-saving cancer diagnosis. Plus, you have to give the pathologist a proper clinical history on the form.
You can't just send a jar with a name on it.
No, a piece of tissue without context is useless.
Which brings us to the most human element of this entire process. Diagnosing the pathology is a massive technical hurdle, but the ADC exam aggressively tests how you actually communicate these complex issues to the patient.
Yes, the communication tasks test your empathy and your ethical boundaries just as much as your clinical knowledge.
Let's look at an actual scenario from the ADC communication task sources. A 45-year-old patient comes in with a massive 20-year-old silver amalgam filling, complaining of sharp pain when chewing.
The classic cracked cusp presentation. You'd want to use a diagnostic tool like a tooth sleuth or a frac finder to pinpoint the exact cusp flexing under load.
Right. But how do you actually script the conversation to tell them their tooth is fracturing, especially when it means they might need an expensive crown, or maybe a referral to an endodontist?
You have to be transparent about the mechanics and the options. You explain that binding the tooth together is necessary to save it, And importantly, you explicitly inform them that a specialist referral will incur additional financial costs.
But what if they balk at the cost? What if they say, I can't afford that, just pull it? Do we just refuse because we prefer to save teeth?
This is a massive ethical test in the exams. You must manage their reluctance while adhering to your duty of care. Extraction is a viable last resort, but you have to ensure informed consent.
So you detail the long-term consequences of extraction, like adjacent teeth drifting and bone loss.
Exactly.
Yep.
Ultimately, the choice belongs to the fully informed patient.
Let's pivot to a post-op complication, the dreaded dry socket. 3 days after pulling a lower molar, they call the clinic in agony with a foul smell.
Alveolar osteitis. And patients almost always panic and demand antibiotics because they assume it's a raging systemic infection.
Right, so how do we communicate the reality of a dry socket?
You strip away the medical jargon. You explain that the protective blood clot simply dissolved too early, leaving the raw bone exposed to air. You reassure them that you'll gently wash it out and place a soothing dressing, like Alvegil, directly into the socket.
And you firmly explain why antibiotics won't help because it's a delay in healing, not a bacterial infection. We just prescribe stronger painkillers.
Spot on. It's all about managing their expectations.
Now, here is a really tricky communication scenario. A patient comes in wanting all their perfectly good amalgam fillings replaced because a naturopath told them the mercury is causing chronic fatigue.
Oh, this is a profound test of your duty of candor.
Because it's so tempting for some clinicians to just say, sure, drill them out and bill for a bunch of new composites, right?
Which is entirely unethical. The evidence-based strategy here requires you to gently but firmly present the scientific consensus. Routine replacement of sound amalgams is contraindicated.
Because drilling them out actually releases transient mercury vapor.
Exactly. Plus, you destroy healthy tooth structure in the process, weakening the tooth.
But you still have an unhappy patient. What if they pivot and say, I understand the science, but I just hate how dark they look when I smile? Can we find a middle ground?
Yes, that is where professional empathy comes in. You can offer a compromise based purely on aesthetic concerns, like replacing only the fillings in the smile line, typically the premolars.
So we validate their aesthetic desires while still upholding our professional boundary against unnecessary operative trauma. I love that.
Perfect ethical balance.
This brings us to a complex overlap. We've talked about localized pain, but the source material, especially Renton and Thompson, dives into much broader, highly complex presentations of orofacial pain and swellings.
Yes, because a swollen face requires you to rapidly categorize the etiology. You must distinguish between acute odontogenic sources and non-odontogenic pathologies.
Odontogenic being our bread and butter, like an acute periapical abscess or pericoronitis from an inflamed wisdom tooth operculum.
Right, where the treatment is localized and decisive irrigate, drain the pus, or extract. But the clinical reasoning gets incredibly murky with non-odontogenic cases.
Like Odell's cases 8 and 66, right? Painful trismus or severe head pain with absolutely zero evidence of dental decay. What is our move there?
This forces the clinician to look beyond the dentition. We have to consider temporomandibular disorders, or TMD, involving massive muscle spasms, or neuropathic conditions like trigeminal neuralgia.
Which means the treatment isn't a dental drill.
No, drilling a tooth will not cure trigeminal neuralgia. These conditions mandate a multidisciplinary approach, potentially coordinating care with physical therapists or neurologists.
Which perfectly brings us back to that cognitive architecture we started with, the ability to synthesize the entire clinical picture without bias. Before we wrap up, I want to ask you for one final provocative thought. Where is the future of this diagnostic problem-solving heading, especially with the 5th edition of Odell on the horizon?
Well, the most disruptive element introduced in the upcoming 5th edition is the integration of artificial intelligence and assisted intelligence. We're entering an era where AI algorithms will assist in caries detection and analyzing radiographs with incredible precision.
Oh, wow. So it's a massive technological leap.
It is. However, the ultimate takeaway is that AI is merely an adjunct. It's a tool, no different than a CBCT scanner. An algorithm cannot sit knee-to-knee with a terrified patient and deliver a squamous cell carcinoma diagnosis with human empathy.
Or ethically negotiate an amalgam replacement compromise.
Exactly. The final synthesis of the evidence, the ethical responsibility of the treatment plan, and the deeply human communication of that reality will always remain entirely on your shoulders as the clinician.
So even when AI hands us a sharper image, it is still up to the human practitioner to navigate those waters with the patient.
The technology provides the map, but you always steer the ship.
For more dental examination prep tips and clinical deep dives, please subscribe and share this episode.